Well, we're at the very last part here. We're going to do the review for the final for pulmonary diagnostics. I've kind of put it into a PowerPoint, just like we have done the last time we reviewed for a test. I would recommend that you print out the PDF and take some notes because not everything is written out in PowerPoint form, so you will have to listen to the lecture to make sure you get all of the information. Let's talk about some key points here, such as what do we need to look at before we even start a test. Some of the most important things to know about a patient that you're going to put into the pulmonary function report are things like past medical history, their pulmonary history, and occupational history. Yes, we want their age, height, all those type of things, but more importantly, what has been going on with their past medical history. Do they have something happening that would perhaps affect their respiratory system? Their pulmonary history, are they an asthmatic? Do they take medications now? Are they a COPD? Or do they have restrictive lung disease? Have they worked in a coal mine? Have they worked in a place where they're cutting stones? Any of those types of things. Do they work in, are they a farmer? Do they have farmer's lung? Occupational history is every bit as important in a PFT as is your pulmonary history. So, key point there, occupational history, you really should be getting. There are some things that could delay the test, so you obviously want to know those if they can't do it. Maybe they're too confused today. Maybe they're too short of breath today. Maybe they're coughing up blood, they're in a lot of pain. If they've recently used their bronchodilator, typically we like to stop bronchodilator use if we're going to be doing a post-study for at least 8 hours, and in some cases, certain medications, 12 hours. That can be a challenge for people who suck on those inhalers every 4 hours, so keep that in mind as well. You want to look at that because if they've taken a bronchodilator, especially a maintenance bronchodilator, not their anti-inflammatory piece, but the maintenance one. If you've got Advair has a long-acting bronchodilator in it. So if they've taken that doing our pre-testing, our pre-spirometry, are we really seeing a clear picture of what they are? No. So that's why we don't like for them to take their medication. Some indications for pulmonary function studies would be we're trying to evaluate a pulmonary disease. They have a symptom. They're short of breath. They feel like they're coughing all the time. They feel like there's something squeezing on their chest and it's not cardiac. Preoperative evaluations, they're getting ready to have. Usually this is reserved for major surgeries like abdominal or thoracic surgery, sometimes neuro, depending. Treatment evaluation, that you've done PFTs, you've decided that they have an obstructive pattern and you want to, 3 or 6 months later, you want to evaluate them and see if you've made a difference. And of course, occupational evaluations, like we talked about before, doing Tony's Pizza. Another piece that I did not put on here is disability determinations. So those are some of your indications. What are some absolute, positively, no matter what, don't do contraindications of pulmonary function studies? The two key ones is pneumothorax. They have a pneumothorax, you're probably not going to want to do a PFT. Even if it's been treated, you probably don't want to do a PFT because if their pneumothorax hasn't totally resolved, even with the chest tube in, you're going to lose some of the volume through that chest tube, therefore it's not going to be an accurate test. And then obviously frank hemoptysis. Somebody who's coughing up huge amounts of blood has no business doing pulmonary function testing maneuvers. Okay, we talked about ATS recommendations. Remember, ATS is the American Thoracic Society. There's a lot of stuff. If you want to read on ATS recommendations for PFTs and you want to read the whole book about it, knock yourself out. But the key thing, these are the key things about it that you would need to know at your level. Now, if you go into pulmonary diagnostics in a full-scale lab at some point in time, you're probably going to want to brush up on these a little bit more than what I'm covering here today. Make sure you do your calibrations. Usually for PFTs, you calibrate it every day. And most of the time, that's adequate. If you don't use your PFT machine every day, then in a lot of institutions, they choose to calibrate it before each use, unless you're going to be using it several times in one run. You want to make sure that it's consistent. So, for example, if you're using a calibrating syringe for your spirometry and looking at your flow transducers, even in lung volumes, you want it to be plus or 3% of what the calibrating syringe was. So, if the calibrating syringe is 3 liters, you want it to be about, 2.9-ish to 3.10 would be acceptable. That's plus or minus 3%. Another thing that they really stress is reproducibility. So how do we do that? We try to get 3 recommended similar tests, whether that be spirometry, that be lung volumes, that be DLCO. We're looking for that reproducibility. Keep in mind, we did say that not everybody can always do 3, but that is the gold standard that we should attempt to get all the time. All right, some things about spirometry to know. You want to realize that on a spirometer, you can have a flow and measuring devices where we're measuring volume, and we're also looking at flow. So you have a flow volume measuring devices. It is the most common test done to evaluate bronchodilator effect. Only stands to reason if we're looking at obstruction to airflow and if it's improving, we want to see how long it took them to get that air out, and that's what a spirometer does. Peak flow, key point, peak flow is the best indicator of patient effort. Peak flow, okay? Spirometry cannot measure residual volume, therefore it cannot measure FRC or TLC because those capacities are included, RV is included in that. Okay, a flow volume loop is the most common test you're going to see today. Yes, you can do your volume over time, and most flow volume loop systems will print that graph out as well. But the flow volume loop is awesome at being able to measure flows. We like to look at if there's a decrease in flows. We can see it very easily in a flow volume loop. Do we have an obstructive lung disease? Is there some other obstructives to flow? The flow volume loop can show us if we have some fixed obstructions. Remember when we went through interpretations, an inspiratory maneuver, if it flattens out, you probably have something going on with your vocal cords. An expiratory maneuver that flattens out at the top, you might have something going on with your vocal cords. You might have a large mass that's in the way. So anything that's obstructing flow can be seen with a flow volume loop. Normally we exhale about 75 to 85% of the FVC in 1 second. So that would be our FEV1. Normally our FEV1 is 75 to 85% of the total that we have to blow out, when we should get that out in a second. The FEF 2575 is the best for evaluating small airway disease. Okay, the 2575 is best for evaluating small airway disease. Therefore, it is best for evaluating the effects of cigarette smoke on small airways. Okay? Keep in mind that when we talk about cigarette smoke, we're not just talking about an upper bronchitis. The smokers get bronchitis all the way down into their smaller airways. So the 2575, which is the mid portion of the flow volume loop curve, okay, it's about a quarter of the way in through to about 3/4 of the way. It's the mid portion. It is the best for measuring or evaluating small airways, and it's often what we want to do in smokers. If the FEV1 is decreased and there is a normal FVC, it only stands to reason that you have an obstruction to airflow. If you're not getting out 75 to 85% of your total amount that's in your lungs in the first second, you have an obstruction. Your FVC may be totally normal, but it may have taken you a long time to get all that air out. So remember that relationship between FEV1 and FVC. If the FEV1 is reduced and the FVC is normal, you probably have an obstruction to airflow. May not know what it is, what's causing that obstruction, but there is an obstruction. When you evaluate if bronchodilators are helping with that obstruction to airflow, After you give the bronchodilator, you want to wait 15 to 20 minutes. I believe Egan says 15 minutes. Some labs use a standard of 20 minutes. Now, the reason we do that is because we want the drug to reach its peak effect before we reevaluate and see how effective it is. If we gave them a breathing treatment, we gave them an MDI, and then immediately did a spirometer on them again, we wouldn't really see the true peak effect. We might see some change, but not the peak effect. So we want to wait 15 to 20 minutes before we repeat the test and do a post-bronchodilator spirometry. Okay, next, lung volumes. We use lung volumes to determine all kinds of volumes and capacities, but it also allows us to measure residual volume. If we can measure residual volume, then we can measure TLC and FRC. The tests we use to do that are helium dilution, nitrogen washout, or body plasmography. With helium dilution, basically you start with a certain percentage of helium, and you're waiting for equilibrium of that helium to occur. Okay? You're waiting for equilibrium of that helium to occur between what's in the system and what's in the lungs. And then based on that and a bunch of calculations, they determine what the estimated lung volume is. Not a bad test, but there are better tests out there. The next one is nitrogen washout. Nitrogen washout, basically what happens is it washes out all of the nitrogen. So you're using 100% oxygen. Helium dilution is actually used more than nitrogen washout. It's obvious we're giving 100% oxygen. And, a lot of times people are very leery of that due to hypoxic drive and O2 toxicity, etc. So the two of these, the problem and the limitation with helium dilution and nitrogen washout, both of them is they don't necessarily give you a true total lung capacity, because if there is air trapping, then there's going to be no communication to wash out the nitrogen or to dilute with helium. Therefore, those are not in the equation, and you don't always have an accurate TLC. Body plasmography, on the other hand, is based on Boyle's law. Write that down. It's based on Boyle's law. Body plasmography is based on Boyle's law. There's a change in volume, there's going to be a change in pressure. Okay, that's Boyle's law in a nutshell. If temperature remains constant, if you have an increase in volume, you're going to have a decrease in pressure. If you have a decrease in volume, you're going to have an increase in pressure. The body box works on that very same principle. And because it's purely looking at what we call movement within the box and the barometric pressure and what happens with those pressures and volumes within the box as the patient's breathing in or out, it is able to determine true total lung capacity. It doesn't have to be in communication with airways that have air trapping. It can measure true total lung capacity. Okay? It's a little bit more complicated than what we've covered here. But again, if you go into a full lab, my advice to you is to spend a little extra time and review that.